Welcome to the Deep Dive, your shortcut to critical knowledge. Today we're tackling a really high-stakes neurological puzzle, idiopathic intracranial hypertension. You might know it as IIH, or maybe by its older name, pseudotumor cerebri. At its core, this is about dangerous pressure inside the head. We're talking elevated intracranial pressure, ICP, but then this is key. We just can't find a tumor or any other known cause. That idiopathic part is central. But, for the patient, the really critical question is, why is this so urgent?
Yeah, the urgency is all about vision. It's true, the patient often suffers from these really debilitating headaches, chronic ones often. But the most serious threat is that constant high pressure pushing on the optic nerve.
Okay.
That pressure makes the optic disc swell up. That's what we call papilledema. And if we don't get that pressure down and quickly, the risk is severe, permanent vision loss, irreversible.
Wow, irreversible. That definitely makes every step in diagnosis feel like a race against blindness then. So our mission today is to give you the precise playbook, how to spot the IH patient, navigate the tricky diagnosis by exclusion, and figure out when it flips from medical management to needing surgery. Like right now. Okay, let's unpack this.
Absolutely. And we have to start with the most critical clinical pearl, really. It helps narrow your focus immediately. IIH overwhelmingly, really overwhelmingly, presents in a very specific group, young, often obese, biological females of reproductive age.
That's specific demographic.
That profile is your anchor, seriously. If you see someone with symptoms that suggest high ICP, bad headache, visual changes, but they don't fit this picture, then you absolutely have to prioritize other potentially more dangerous things first. Think venous sinus thrombosis right away.
That's such a vital distinction. Okay, so let's zoom in on the history that just screams IIH. What are these patients actually telling you besides just I have a headache?
Well, the headaches are often severe, yeah. And they might mention it gets worse with straining, like a Valsalva maneuver. But the visual symptoms, those are often the real giveaway. Things like transient visual obscurations.
Transient visual obscuration,
Oh,
like
yeah.
fleeting vision loss.
Exactly. Vision loss that lasts maybe just a few seconds, and it's typically linked to changing position.
Right. They might say it happens when they bend forward. I remember hearing the classic, almost funny example, like when bending over to pick up a heavy neurology textbook. It's just for a moment, maybe 5, 10 seconds, but it must be terrifying for them.
Yeah.
And along with that, maybe blurred vision or even seeing double.
Yes, blurred vision and double vision are common too, but there's another symptom you mentioned.
The pulsatile tinnitus. That one always stands out. It's not just a regular ringing, is it?
No, not at all. Pulsatile tinnitus is a fantastic clinical sign here. It's like a whooshing sound, often in time with their pulse. What the patient is actually hearing is their own circulation. It's sound transmitted directly from turbulent blood flow.
Turbulent flow.
Because that high pressure literally narrows the transverse and sigmoid venous sinuses in the head, it creates this turbulence, this noisy flow that they can perceive. So they are, in a way, hearing their own high-pressure system struggling. It's a really neat teaching point.
That makes perfect sense. And before you move off history, connecting history to cause, or maybe lack of cause, medications. This seems really important. Trying to link potential triggers to this supposedly idiopathic condition. Are there specific drugs we absolutely have to ask about?
Oh, absolutely. Crucial question. You need to specifically ask about any history of using tetracycline antibiotics and also any form of retinoids. That includes things like vitamin A derivatives or medications like all-trans-retinoic acid, sometimes used for acne or certain cancers. These drugs have a known, pretty strong association with either triggering IIH or making it worse. Gotta get that documented straight away.
Okay, tetracyclines and retinoids. Got it. So the history is pointing strongly towards IIH, especially with that pulsatile tinnitus and the vision loss when changing position. What about the physical exam? What findings help confirm our suspicion and keep IIH high on the differential list?
Right, the exam. First off, the general status is really key. Typically, these patients are normotensive, their blood pressure is normal, and importantly, they usually have a completely normal mental status. They're alert, oriented.
Why is that so important?
Because it helps you differentiate IIH from, say, a hypertensive emergency or malignant hypertension. In those cases, you'd expect really high blood pressure and often some confusion or altered mental status. If the patient's alert and BP is normal, it pushes you more towards IIH.
Makes sense. Then comes the critical moment, probably the fundoscopic exam, looking into the back of the eye. What are we looking for there?
Papilledema, that's the absolute hallmark finding we're looking for. You'll see the optic disc looks elevated, swollen, and the edges, the margins will be blurred because of all that pressure pushing from behind. And beyond just looking, if you do formal visual testing, you'll almost certainly find things like visual field loss, maybe blind spot enlargement and decreased visual acuity.
Okay, papilledema is key. Beyond the direct vision findings, is there a specific neurological sign that really points towards that dangerously high pressure inside the skull?
Yes, there is. That increased pressure can physically stretch one of the cranial nerves, specifically the sixth cranial nerve, the abducens nerve. It's quite vulnerable as it travels up the skull base. So this stretching can cause an abducens nerve palsy, either on one side or sometimes both. It's a classic sign of high ICP.
An abducens nerve palsy. Can you walk us through what that actually looks like for the patient? How does that manifest?
Sure. So the abducens nerve, cranial nerve 6, controls the lateral rectus muscle. That's the muscle that pulls your eye outwards away from your nose. So if you have a palsy, let's say on the right side, when the patient tries to look straight ahead, that right eye might drift inwards towards the nose. And even more obviously when you ask them to look towards the affected side, so look to the right. In this case, they physically won't be able to move that right eye outward past the midline. The muscle just can't do its job because the nerve supply is compromised by that stretching from the high pressure.
That paints a really clear picture. Okay, so suspicion is high based on history and exam. The next step is ruling out structural problems, right? So that means ordering brain imaging, specifically an MRI. And crucially, you also need venography, like an MRV.
Exactly. Brain MRI with venography, the MRV part, is essential to look at the venous sinuses. You have to rule out a clot, a venous sinus thrombosis. And once you have that imaging, assuming it's clear, what comes next is, well, it's invasive, but it's absolutely essential for diagnosis.
The lumbar puncture.
The lumbar puncture, or LP, yes. You have to do it.
Yep.
Not just to get a sample of the cerebrospinal fluid, the CSF, for analysis, but critically to measure the opening pressure. You need that number. That pressure reading is the definitive measure here.
Right, the pressure. If we connect this to the bigger picture, this is why we call IIH a diagnosis of exclusion, isn't it?
Precisely, because you must rule everything else out before you can confidently stick that idiopathic label on it. So if the MRI or MRV shows any structural issue, like a tumor, hydrocephalus, or that venous sinus thrombosis we mentioned, it's not IIH.
Okay.
Also, if the LP opening pressure comes back normal, it's not IIH. Or if the CSF analysis itself is abnormal, say high white cells suggesting infection or high protein suggesting inflammation again, you exclude IIH and chase down that cause instead.
So, assuming the imaging is totally clean, no structural issues, no thrombosis, what are the definitive diagnostic criteria from the LP?
Okay, assuming clean imaging, you need two main things from that LP. First, the opening pressure must be clearly elevated. The usual cutoff is at least 25 centimeters of water. And second, the CSF fluid itself, when you analyze it, must have a completely normal composition. Normal glucose, normal protein, normal cell count.
25 centimeters of water and normal CSF contents.
Got it. Now, I find it interesting that while those are the strict diagnostic criteria, the MRI often shows some other subtle clues, right? Things that might support the diagnosis, even if they aren't required.
Oh, definitely. They are valuable clues, for sure, and often reinforce your suspicion before you even do the LP. We commonly see things like an empty cella turcica on the MRI, where the space for the pituitary gland looks empty because it's squashed by chronic pressure. You might also see flattening of the back of the eyeball, the posterior globe, or dilation of the optic nerve sheaths, kind of like the nerve is wearing a turtleneck that's too tight.
And often you'll see that narrowing or stenosis of the transverse venous sinuses that we've talked about causing the pulsatile tinnitus. Slit-like ventricles sometimes too. So yeah, seeing those findings makes you feel much more confident going into the LP, expecting to find that high pressure.
That makes sense, those reinforcing signs. Okay, so the diagnosis is confirmed clean imaging, pressure's high, CSF is normal. What's the immediate next step? It sounds like it involves assessing the threat level to the patient's vision.
Absolutely. Critical differentiation time. You have to figure out, is this typical IIH or is it the much more dangerous fulminant IIH? It all hinges on the vision.
Fulminant IIH. How do we define that emergency state?
Fulminant IIH is all about the speed of vision loss. We define it in two main ways. Either the time between when symptoms started and when severe vision loss occurred is less than 4 months. That's pretty rapid. Or, even more acutely, if the patient reports really rapid, drastic vision decline happening over just a few days. That signifies a true surgical emergency.
Okay, that's clearly the danger zone. Let's start with the more common non-emergency scenario first. Typical IIH. The immediate threat isn't there. What's the standard path forward?
Right. For typical IIH, the treatment focuses immediately on long-term management and trying to lower that pressure steadily. Lifestyle changes are really foundational here. Significant weight reduction is key, often strongly encouraged, sometimes even involving referral for bariatric surgery consults. And alongside that, you need aggressive management of their headaches. But pharmacologically, the cornerstone is using carbonic anhydrase inhibitors.
Carbonic anhydrase inhibitors,
Mm.
their job is to reduce CSF production, right? Acetazolamide is the main one.
Exactly. Acetazolamide is the primary drug. It works by decreasing the rate at which the body produces CSF, so less fluid means lower pressure, hopefully. But as anyone who's prescribed it knows, it can come with some pretty notorious side effects.
Oh yeah, the tingling, the weird taste.
Definitely. Paresthesias, that tingling in the hands and feet around the mouth, are super common. Altered taste, especially with carbonated drinks, fatigue. It can be a tough medication for people to stick with long term.
So if they just can't tolerate acetazolamide, is there an alternative?
Yes, thankfully. If compliance is a major issue due to side effects, topiramate is often used as a viable alternative. It also has some carbonic anhydrase inhibition activity, helps with headaches, which is a bonus, and can sometimes promote weight loss. So it's a good second-line option for CSF management.
Okay. But what if, despite being on medical management, say acetazolamide or topiramate, trying to lose weight, their vision actually starts to get worse? What happens if they show an inadequate response visually?
That's the trigger point for escalation. If visual function deteriorates despite medical therapy, you continue the medical management, but you also now have to strongly consider surgical procedures. The goal shifts to directly decreasing the pressure on that optic nerve to save sight.
And what are the surgical options at that point?
There are mainly two approaches. The first is called optic nerve sheath fenestration. This is a very targeted procedure where a surgeon makes tiny slits or windows in the sheath surrounding the optic nerve right behind the eye. This lets CSF sort of leak out locally, relieving pressure directly on the nerve.
Okay, a local fix. What's the other option?
The other, more systemic option is surgical placement of a CSF shunt. This involves putting in a tube system, like a ventriculoperitoneal VP shunt, or maybe a lumboperitoneal LP shunt, that actively diverts CSF away from the brain and spinal cord, usually draining it into the abdominal cavity. This lowers the overall intracranial pressure systemically. And a potential long-term benefit is that some patients with shunts might eventually be able to taper off or even stop their carbonic anhydrase inhibitors.
Right, it provides a more permanent drainage route.
Uh-huh.
Okay, so that covers typical IIH and what happens if it progresses. Now back to that emergency scenario. Fulminant IIH, that rapid, immediate threat to vision. Does the management change fundamentally there?
Fundamentally, in terms of timing and urgency, yes, absolutely. You still initiate all the medical treatments we discussed. Aggressive weight loss efforts, headache management, starting the carbonic anhydrase inhibitors. But crucially, you add immediate, time-sensitive surgical intervention right away. You don't wait to see if the medications will work.
So straight to surgery.
Straight to considering surgery, yes. Either the optic nerve sheath fenestration or CSF shunting needs to be performed urgently, usually within days, to decompress that optic nerve and save sight. The clock is ticking loudly in fulminant IIH.
Okay, that urgency is clear. So what does this all mean? If we bring it back together for the learner, what are the absolute key takeaways?
I think it means that idiopathic intracranial hypertension is really a clinical picture built on a few highly specific things. You've got that classic patient profile, first off. Then the absolute necessity of ruling out all other structural causes with imaging. And finally, confirming it with that specific elevated opening pressure threshold, 25 centimeters of water or more during the LP with normal CSF fluid. But ultimately, maybe the biggest takeaway is that the patient's visual status, how their vision is doing and how quickly it's changing, is the single most critical factor. It dictates the entire urgency of your treatment plan, deciding whether you manage medically or intervene surgically right now.
That's a great summary. And that takes us perfectly to our final provocative thought for you, the listener. The fact that we still have to use the word idiopathic, meaning of unknown origin, for a condition that can cause such severe vision-threatening symptoms is, well, pretty remarkable in modern medicine, isn't it? It really raises these profound questions about how much lifestyle factors, particularly something like obesity, truly influence the incredibly fine-tuned mechanics of CSF production, absorption, and flow. And looking forward, you have to wonder, will we eventually move beyond just managing the pressure? Could we one day see novel drugs that actually target and maybe even reverse that venous sinus stenosis we so often see on imaging in these patients? It feels like a space where truly understanding the cause could completely redefine the cure, something for you to consider as you keep learning. Thank you for joining us for this deep dive. We hope this knowledge accelerates your understanding.